Hello there. Thank you for the opportunity. Now, by raise of hands, can you show how many are already doing radial in your practice? Okay. So we will cover some of the basics, but some tips and tricks that personally we feel could be helpful. No disclosure. We know change is hard, and it's been nearly 2 decades since initial case reports for neuroangiography through radial approach was discussed. Now, just like it took about 2 decades for Barbarian to become Terminator, I'm expecting that you guys will catch up. So our experience also came late. Only about 2 years ago we started. We have more than 1,000 radial cases, and that would be our base for some of the points. So when you divide this procedure, you have first thing is access, then catheterization, and then hemostasis. Hemostasis, there are not too many tips, just patent hemostasis. So we will spend more time in the first two. And some of the generic tips will be plan your angio through radial if you are going to do this. Go review your CTA or MRA neck. Just look at the arch, how it is, how is the subclavian, bovine, no, not bovine, any variant in the arch that, because initially you want to build your confidence. If in general you can do Allen's, Barbo and other things, but right now majority of the people believe if you can feel the radial artery, you can get it. And use ultrasound whenever possible. Even though it sounds cumbersome, it has been shown to lower time for access, and we will discuss that later, and other speakers will talk about it. In addition, what I found is we assess the size then and there for not only radial, many times ulnar. Also, when we look at radial artery bifurcates into two branches at the same wrist crease. So you can pick the bigger diameter because some of the branch, after it bifurcates, it loses its lumen. So you pick above the bifurcation initially, so less risk of spasm. Some of the guys are also doing antecubital ultrasound along with the radial just to see if they can sort out any major loops or something. Now, some of my colleagues are doing this distal transradial approach as the first approach for diagnostic angiogram, and then conventional radial for future, because there is still a risk of radial artery occlusion as high as 5%, and plus theoretically there is lesser risk of ischemia. So some people are reserving it for Barbo test if you have type D, where you actually occlude and you have a flat wave on pulse ox, and it's not coming back. So now this becomes a concern to some people, even though it has not been proven by any evidence. So this is, in my experience, it's a little bit harder learning curve for distal transradial, plus it's about 20% smaller lumen. So you can definitely try this. It is more convenient for the patient. Positioning is easier because you can easily bring, hand is kind of this position, so it really imitates your groin puncture, and bring it next to the groin and do it. Typical setup, most of you actually keep the monoplane initially if you want to do a run, or you want to see the wire coming out of your sheath or your micro wire. So 15 degrees clockwise rotation, you keep that and follow it. Now, this is very standard, but some of the tip I can give you, be comfortable with the technique that you get used to. Shallow angle is better angle because you won't hit the wire, and if it is more in alignment with the lumen, it will cross easier. You don't want to cause spasm initially, otherwise you'll get frustrated. So start to learn that shallow angle, and that's where ultrasound really helps me. If pulse is not good, if you don't feel very good pulse here, you can ask your assistant to compress a little bit distally. So what happens is now blood is not going further, and you start feel the pulse better if you're gonna, especially if you're gonna blind, and always use hydrophilic sheath. Now this was, in this you can see radial artery bifurcates into superficial and deep palmar branches. So if you go blind, there is a good chance you might hit the superficial, the lower one, which has smaller lumen, and may cause spasm. You may get frustrated, but also remember that if you're going a little bit distal, many times you may lose pulse here and will have spasm. You can always go proximal. So just get your spot, that sweet spot if you're going blind, but ultrasound, that is where ultrasound really helps. We should be familiar with some of the variations that could make the procedure challenging, and they are common. There are almost about 14% of patients will have some tortuosity and loops, and it has been shown already that if you have more anatomical variation, there is a higher risk of procedure failures. Now, when we look at causes of transradial approach through the coronary world, what are the reasons? Loops were predominant reasons, followed by spasm, sometimes guide wire dissection, and also subclavian stenosis. And these are similar because in our neuro also you have to reach the arch. So in our experience, we are finding the similar challenges. Now, some people do routinely pre-procedural radial angiogram. Some people do not. That will be your judgment, but it has been shown by evidence that if you do the angiogram, you can plan it better and you can avoid many complications, as we'll see. So in our practice, we do microwire during insertion. If there is any resistance, we do fluoro around that wrist and see the wire, how it is going, is it looping or not. If there is any question, we do radial angiogram. And if there are small branches coming around, you see a loop and all that, it's better to use a J-tip wire. Otherwise, sometimes the regular glide wire will try to go to those small branches. If you have stenosis or loop or tortuosity and your wire is not going easy, even the J-tip wire, use a micro wire. And then you can put your diagnostic catheter a little bit distal. You can always exchange it out. Once it is beyond, then you can put your regular, because most of the time, simple tortuosity and some basic loops, they will straighten. And sometimes balloon assistance also is helpful, where you take a small balloon, let's say 2 millimeter balloon, you inflate it, put it at the tip, and over the microwire you thread it, and it can go. Use of J-tip wire, many of my colleagues are using it routine for every case. They will use a J-tip only because you can avoid fluoroscopy. Essentially, that's the advantage. You don't want to do your angiogram, you don't want to see your wires going in. J-tip usually helps a lot, and typically by the time you push and fluoro, you are already in the subclavian. If you do have high bifurcation, that typically you see if there is a resistance or you have done an angiogram and you see a higher bifurcation. In that scenario, a long sheath will be desirable because it's the friction of catheter. When you are twisting and torquing, you will have more spasm in that area. So longer sheath in that scenario will be better. Now, spasm is definitely a concern in these cases. And some of these patients who are low body mass index, short stature, young females, small wrists. So those patients have higher risk for spasm because of the smaller arteries. So in those cases, or you can do routinely, typically what you can do is, as Amir mentioned, you can do some topical lidocaine or prilocrine before the start of the procedure. So that really helps. When you puncture, they are less anxious. Give good sedation in those patients. Also, you may apply nitropaste. Let's say you didn't put anything before, patient is there. Some people even do subcutaneous nitroglycerin. I put nitropaste in small vessels if I feel there could be a problem. And of course, you do your vasodilators, longer sheath in those especially small patients. If you get severe spasm during the case, what do you do? This is a common scenario, actually, relatively common, that most of you will start having that issue within 50 cases. So start with warm compresses, ulnar artery compression, if you do ulnar artery compression, there will be compensatory vasodilation in the radial artery, and sometimes that will help. Take your time, don't rush, don't pull. So ultimately it comes out. Give a little bit more sedation. And rarely, especially for intervention, sometimes bigger sheath or bigger guide catheter may really get stuck, and then you have to call your surgeon. Sometimes it helps general anesthesia, regional block, or surgical removal. So this one is showing you the basic things. This is by Priyank and his group, Dr. Patel. They recently wrote a neuroradialist review article. So you see over the microwire, he does a run and then put a J wire. And then in this case, they're putting a longer sheath, exchanging it for a longer sheath. And then they take the catheter into the arch. You reconstitute your catheter, and you do your... Now in this catheter angiogram, catheterization, basic point is you do biplane. Make sure Siemens is usually the catheter of choice. You look at the knee of the catheter in the arch, in the AP view, and in the lateral view, you want to see the wire tip. So that way you can prevent herniation when you are pushing the wire. And in my experience, shapeable glide wire sometimes helps. If you don't want to go to the arch, many times the wire will go directly to the right common. You take it and then you push the Siemens knee into the arch directly. Or if you deliberately do not want to go to the arch, just shape your wire, and most of the time your catheter will go to the common. So these are common reconstitution methods. Descending aorta and ascending aorta. Descending is usually more elegant way of doing it. Ascending, because you are hitting against the aortic valve, sometimes calcification, and there is theoretical risk of stroke in that scenario. And in these cases, routinely you do give heparin to prevent radial artery occlusion, so that also helps in that scenario. So you can see if you know your Siemens catheter, it's not a problem. I think you can reconstitute in different ways. You will have your own scenarios. So in these two videos, you can see the wire is coming down into the ascending. It loops around. It hit the aortic valve. You push your catheter, and you remove the wire. You have reconstitution. Here, you push the wire across, then remove the wire and push down on the knee there, the proximal curve, and catheter herniates into ascending, making reconstitution. This is another one. Let's say in this arch, it would not form anyway. So it went all the way to the descending. You can just twist, make a loop, pull back, and you can reconstitute. And in this scenario, for example, the wire is going directly to the right common. You push your catheter up, remove, and then this you can push down. This is the left. So once your catheter is reconstituted in the right or left or subclavian, wherever you are, you want to keep that form. So sometimes you have to just torque it and push it or pull it, but as long as you have the orientation, I don't think you need to reform the catheter again once you form in any of these vessels. Left vertebral artery is always a concern for majority of the people. If you feel your intervention depends on left, then maybe just go to the left radial so you don't face challenges. But if you are going to the right for diagnostic and you have other vessel of interest, and left is also a vessel of interest but not the primary vessel, then you can do it. Sometimes Siemens 2 falls short, so you can do Siemens 3 in that scenario. Also, what we have realized is if you catheterize from descending aorta versus ascending aorta, the vector is very different. For example, in this one, it's very hard curve to take it to the leftward. So you can take a wire, push it to the subclavian, push your catheter into the subclavian, remove your wire, you torque it, you just form a vector that you want to go to the descending rather than the ascending. And once it goes to the descending, your vector is so straight for leftward, it will work just like transfemoral. Right word, most of the time you do it in the beginning of the procedure or in the end of the procedure because you don't need reconstitution, but sometimes orientation is such that it becomes easier to go through just like you do right common. So you just look at it, there is no hard and fast rule in this diagnostic cerebral angiogram. I think people get bored after doing transfemoral once they have done thousands, it's another, so it's good to take transradial, it brings some excitement. Now, subclavian tortuosity is very important. I think that is really a big concern for me because this is one scenario where you are torquing and torquing your Siemens, and if you're not paying attention, you can form a kink. Not only kink, you can form a note. Once you form a note, you are in trouble because then you have to either unnote that or you will have to remove it, and there are some bailouts for that. But if you see that, make sure you're paying attention to how much you're torquing. Sometimes the stiff wire, when you're putting it, it will straighten that loop. Sometimes Siemens 1, even though if it is more proximal and you're not going leftward, then that it is less prone. Straightening that tortuosity in the subclavian by asking the patient to take a breath, turn the head to the left and chin up. It sometimes helps you with the catheterization. And of course, you can, if you have a bigger catheter, you can use a parallel wire to straighten the loop or a balloon-assisted tracking. So this, for example, these loops, you are trying and you are paying attention, mainly you get mainly focused on catheterizing the artery and you forget that your Siemens is making loops. So Siemens 4 French is more prone because it's more flimsy. Pay attention to your arches. Some of the arches are not very good. We have done some of these arch variants, but we had a lot of fluoro time, and we realized it was not a good idea. Hemostasis, the only tip is patent hemostasis. So in the sense that you don't want to occlude this radial, that's not your intent. You want to inflate the air, it becomes occluded. You have your pulse ox, and then if you have your radial or your ulnar, you occlude the ulnar. Now you start deflating this, and you want to make sure with ulnar occluded, you still have flow. So that's the main thing, but thank you so much for giving me this opportunity.